Today, treatment-resistant depression. What it means, what to check before using the label, and what focused options exist. Treatment-resistant depression can sound like a final diagnosis. It is not. It is a clinical signal that depression has not improved enough after treatments that should have had a fair chance to work. There is no single universal definition of treatment-resistant depression. A common regulatory threshold is inadequate response after at least 2 adequate antidepressant trials from at least 2 different antidepressant classes, meaning dose, duration, tolerability, and adherence were all reviewed. Guidelines and trials use different thresholds, and this affects prevalence estimates. Some require 2 failures, some 3. What counts as adequate also varies. This inconsistency matters when interpreting research or navigating treatment options. Before accepting true resistance, clinicians look for pseudo-resistance, when treatment appears ineffective because something else has not been addressed. This includes misdiagnosis, bipolar depression, psychosis, trauma, substances, sleep, pain, medical illness, or adherence barriers. That review includes bipolar disorder, psychosis, trauma, substances, sleep, pain, medical illness, medication interactions, side effects, cost, access, and whether treatment could reliably be taken. Addressing these may resolve what looks like resistance. The goal is not just a lower symptom score. Response means meaningful improvement. Remission means symptoms are minimal. Recovery also considers function, relationships, cognition, sleep, quality of life, and relapse prevention. Focused treatment options start with structure. Optimization means reassessing the current plan and making deliberate adjustments. Switching to a different antidepressant is another path. In the STAR*D switch trial, after an unsuccessful SSRI trial, switching to bupropion, sertraline, or venlafaxine produced similar remission rates, roughly 1 in 4 patients. Outcomes did not differ significantly. Augmentation keeps a partially helpful antidepressant and adds another strategy. In STAR*D, bupropion and buspirone augmentation had similar remission rates after citalopram. Bupropion showed advantages on some symptom and tolerability measures. In a large veterans trial, aripiprazole augmentation had a modest remission advantage over switching to bupropion, but side effect and safety trade-offs differed. Monitoring is required for both strategies. Other options may include psychotherapy, lithium augmentation with monitoring, antipsychotic augmentation with monitoring and shared care, esketamine or ketamine services under supervised conditions, transcranial magnetic stimulation, and electroconvulsive therapy. Treatment-resistant depression does not mean untreatable. It means deliberate next steps. Confirm the diagnosis, measure symptoms, check safety, review barriers, and match treatment to the individual. If someone has suicidal thoughts, psychosis, mania, or cannot stay safe, that needs urgent clinical help.
Questions about today's content or topics you'd like to see covered in future episodes? Drop them in the comments below. And if you found this clinically useful, hit subscribe. More psychopharmacology breakdowns are coming. This video is for educational purposes only and is not a substitute for clinical judgment.